My name is Chris Wallis. I'm the Clinical and Education Manager for our OA and Injury Solutions arm of the business for Asia Pacific. So tonight we'll run through some relevant knee anatomy and the function of the meniscus. And I think to appreciate the management of meniscal injuries, it's good to start with anatomy and function. Then we'll look at the different types of meniscal injuries, risk factors, symptoms and treatment of different types of meniscal injuries. And I'll also run through some changing trends in the management and treatment of these injuries and discuss some of the clinical evidence that support those changes. And obviously throughout where there's bracing options applicable to see where bracing can fit into the management protocols, I will highlight certain products. With regards to the knee anatomy, the two main structures of the knee that are going to be covered are really the cartilage of the knee, that being the fibrocartilage, the menisci, but I'll also touch on the articular or hyaline cartilage. And really it's because these two structures within the knee are so, there is an obvious correlation between the two, and particularly when you think of the degenerative knee joint disease spectrum, these two have profound effects on one another. So particularly when we get damage to the menisci, it has a profound effect on the articular cartilage itself. So injury to the menisci is one of the most prevalent injuries in the human body, and it tends to be the medial meniscus that gets damage greater than the lateral. Its investigation and treatment includes surgical techniques that are among the most commonly performed orthopedic procedures worldwide. As you can see here, the two C-shaped fibrocartilage discs in blue are the medial and lateral meniscus. And I think just something to bear in mind when you are talking to patients or taking a subjective assessment and asking whether patients have had a history of knee injury, just remember that patients often will just say, oh yeah, I've had torn cartilage. So it's probably worth establishing whether that is the fibrocartilage or the meniscus, or whether they've in fact had an articular cartilage lesion or something similar, because the treatment does vary slightly. As far as types of meniscal injuries, the two main categories of meniscal injuries we're going to look at are the acute or traumatic meniscal tears, which tend to affect the younger population. And we'll probably spend a little bit more time on the degenerative or non-traumatic meniscal tears. And these are the tears that tend to affect more of the middle-aged and older population. And they are the most common etiology for patients presenting with knee pain, swelling, and loss of function. So when you think about patients presenting to you that are in that middle-aged to older population, they have not had a diagnosis and they just turn up with knee pain, they've got swelling and loss of function, I guess it's worth establishing exactly what the diagnosis is, and chances are there's going to be a fair percentage of those that are going to have a degenerative meniscal tear that may be causing these symptoms to surface. As I said, I think it's really important to understand the function of the structure that we're dealing with when we're dealing with injured anatomy. And the menisci certainly have several really important functions. So number one, we can think of it as being a shock absorber to the knee. So hopefully you can see my pointer here, but when we look at this, this structure in profile, it's often called the anatomical bow tie. So we've got this, if you think of it as a sponge between the two bone ends. So we've got our femur and tibia articulating. Now the white surface is the articular cartilage, and the red or orange on your screen here is our meniscus in profile. So you can imagine if you had a sponge between two hard surfaces, as those there's axial load loaded down through one, it's going to stop that's going to attenuate the shock between the two hard surfaces. Another important function that continues on with that sort of sponge analogy is the ability of the menisci to provide nutrition for the articular cartilage. So if you imagine that this sponge has also got fluid within it, as axial load is applied to it, that fluid will be expelled from the structure. And that fluid in this case, in the menisci's case, provides nutrition for the articular cartilage and can assist with joint lubrication. Conversely, once the load is removed, that water or moisture can get reabsorbed by the sponge. So that's a couple of the functions of the menisci. They're really also important, increasing joint stability and joint congruency. So another analogy to think of with the menisci, and this is the last analogy, is this tire wedge analogy. So if we think of this wheel on a flat surface, being the wheel being our femoral condyles and the ground being our tibial plateau, then what we've been able to do here, and this is showing one, is increase the congruency of this rounded surface with a flat surface. The meniscus have also been shown to have a proprioceptive function. So within the meniscus, there are mechanoreceptors and nociceptors and all these type of receptors that aid joint proprioception. And another of the obvious flow-on effects of this shock absorber and joint congruency is that by increasing the surface area of the articulation of the knee, we're dramatically reducing these peak pressures. But conversely, if we remove meniscus, we're reducing the surface area and increasing the peak pressures. So that's important to keep in mind when we think about common procedures like meniscectomies, where we're removing damaged meniscal tissue, but we're obviously having a flow-on effect with the joint in the grand scheme of degenerative joint disease. The structure of anatomy often is reflective of what it's there for functionally, and the meniscus is quite a neat structure. So here in cross-section, you can see we've got both radial fibres on the surface. So these radial fibres assist with the shearing that occurs when the femur and tibia articulate through different joint range of motion. But probably more importantly are these circumferential fibres towards the outer surface, and the meniscus is made up of about 85% of the fibres being circumferential. And what this is able to do is convert the axial load into circumferential or hoop stress. So similar to our annulus fibrosus in our intervertebral discs, which are able to convert that axial load into circumferential stress, or if you imagine a balloon in between your hands and squashing it, so it expels it out laterally. So these circumferential fibres are able to withstand that axial load and convert it out into this circumferential stress. So again, when you think of an injury to the meniscus where these circumferential fibres are disrupted, it goes in the reverse. So we want to reduce the axial load because that will actually put stress through these fibres when they're trying to heal. So all of this becomes more apparent when we look at the type of surgical procedures that can occur with meniscal injuries. And finally, it's probably worth noting that the menisci bear 40 to 50% of total load across the joint when it's in extension. So the meniscus and the articular surface are the only structures that are taking the load. So 40 to 50% is going through the menisci, the remainder is going through the articular cartilage. So if there is removal of meniscal material, then it stands to reason that there is going to be an increase in the total load that is then transferred to articular cartilage. So thinking about that big picture and the flow-on effect of what damage to one structure can have on the surrounding structures. Interesting to note that that compressive load that's transmitted through the meniscus increases to 85% of the total load as the knee goes into 90 degrees of flexion. So it is a structure that varies the amount of load that it takes in varying degrees of flexion and extension. Looking at a view from superior to the knee here, you can see we've got our medial and lateral menisci. This is the anterior of the knee, anterior cruciate ligament, posterior cruciate ligament. So whilst there's similarities in the medial and lateral menisci from a functional perspective, when we look at the structures, there are obvious differences. So the medial menisci is more of a semicircle or C-shaped, whereas our lateral is almost sort of 80% of the complete circle. And it obviously covers a greater percentage of this articular surface than the medial. Another key thing to remember as far as differences between the medial and lateral menisci are that the medial meniscus is firmly attached to our medial collateral ligament, whereas our lateral collateral ligament is free of the lateral meniscus. So the medial meniscus does not have the same degree of mobility as the lateral meniscus because it is connected to the medial collateral ligament. We've also got less of our medial compartment covered by the meniscus. So when we think about meniscal injuries, it probably is understandable with this reduced mobility and flexibility of the medial meniscus that it is the more commonly injured. And then when we think about normal joint biomechanics, the fact that 60 to 80% of load is transferred to the medial compartment during non-pathological gait, it stands to reason again that this is the compartment that bears more load, is more prone to articular wear and meniscal injuries. The fact that this medial meniscus is connected to the medial collateral ligament, when we think about posters that I'm sure are in everybody's consult rooms of knee injuries, there's the unhappy triad. So that classic injury on a flexed knee with a valgus stress applied to it, where we damage ACL, medial meniscus and medial collateral ligament simultaneously. The final part of the anatomy that I'd like to cover is just the various zones of the meniscus. So here you can see the meniscus in side profile broken into 3 zones, moving from the periphery into the internal joint surface. So more peripheral, we've got a zone known as the red zone, and towards the internal surface of the joint, we've got a white zone. And what this is referring to is the vascularity of the meniscus itself. And as we know, for tissue to heal, vascularity is required. So that's another important thing as far as the meniscus is knowing where the damage occurs will help determine the surgeons and referring doctors to establish exactly what treatment they're going to do. And if they are going to do a surgical procedure, whether it's going to be a repair or having to remove material because it doesn't stand a good chance of healing if it's in these white zones. A couple of clinical tests which are worth just touching on to help establish presence of a meniscal injury. So probably the most common one is this McMurray's test. So in this, we've got the hip, the patient supine, hip and knee bent. We're able to hold and stabilise the knee along the joint line. So we're able to palpate the joint line at the same time with opposite hand internally and externally rotating the tibia via the foot. And what this will do is that this can elicit pain for the patient that indicates meniscal injury. And sometimes you can palpate a click along the joint line as the meniscus flicks between the femur and tibia during rotation. The next test is the Apley test, or sometimes called the Apley grind test. So in this case, the patient's actually prone, knee bent to 90 degrees, and the clinician is applying an axial load through the tibia, and at the same time applying internal and external rotation. So what this one will do, you can actually, this can elicit, again, that the patient can feel pain, but it can also elicit a grinding sensation, which can help to confirm the presence of meniscal injury. And the final test I thought I'd mention is one called the Thessali test, which apparently is actually the most sensitive of the tests when looking at confirmation or presence of meniscal injuries. So in this case, the patient is asked to stand on the affected limb. They're able to support themselves on the examiner. So the examiner can extend their hands to stabilise them. And on their affected knee, they'll bend to 20 to 30 degrees and internally and externally rotate. And this is something that can reproduce the symptoms on rotation to establish that there is a meniscal injury present. It's always good to know what symptoms to look for, and these are the things that usually drive patients to actually get an injury investigated and treated. So we've got some common culprits here. So pain, and that can be severe, and it's most commonly felt when there's a twisting or rotating motion, as confirmed by those clinical tests we've just run through. Joint line tenderness, joint effusion or a buildup of fluid within the joint, and that effusion can also result in joint stiffness just because of the buildup of fluid within the synovial joint, which then makes it stiffer than it would otherwise. Other symptoms can be things like instability, difficulty in straightening the knee, difficulty deep knee bending, and locking of the knee in partial flexion. So I mentioned the two main categories of meniscal tears being acute and traumatic and degenerative. So we'll start with the acute traumatic and touch on this. So there are a variety, and this is just a selection of the different types of tears that are possible for acute traumatic tears. As the name suggests, these tears are generally as a result of a specific incident. They tend to affect the younger population and the more active population. So as far as risk factors for the acute meniscal tears, these are younger, more active patients with a peak age between 20 and 29, but we're generally looking at patients up to 40, but they can again be younger than 20. Patients that are involved in sports, and particularly sports that involve pivoting and high impact. So on the right, there's a list of some potential risk factors and how they increase the likelihood of injury. So soccer and rugby out of the sporting activities are two that are highlighted there as being particularly bad. But you can imagine netball, basketball, Australian rules football are also culprits for increasing the risk of having an acute meniscal tear. Those that have had an ACL injury, and from the time of the injury to the time that they undergo a knee reconstruction or an ACL repair, if it's greater than 12 months, that will increase the likelihood or increase the risk of the patient having an acute meniscal tear. And you can think of this in that the homeostasis of the knee is affected. So the ACL, which generally controls that AP shift, it is no longer functional, and the meniscus can therefore be damaged more because of the increased relative movement of the femur over the tibia. Similarly, those patients that have systemic joint laxity are at greater risk, just again because of the increasing relative movements between the femur and tibia. And Meniscal tears, these acute meniscal tears, the incidence rate is about 6 in 1,000, and it's suggested that 50% of knee injuries that require knee surgery can have a presenting acute meniscal tear in isolation or in conjunction with other injuries. Treatment of the meniscal tear will certainly depend on the location or zone. So when we think about those red zones through to the white zone, and the type of tear, because this will determine the vascularity and healing potential. So it will help guide the orthopedic surgeon in deciding which of the potential procedures they will conduct. I was recently at an orthopedic knee conference, and anytime the topic of meniscus came up, the underlying message more and more was this: save the meniscus. So trying to salvage or retain as much of that meniscal tissue as possible, because of that established relationship between meniscectomy and increasing the peak load through the articular cartilage when the meniscus is removed. So if more and more repairs are the preferred treatment rather than removing the meniscus, and when there is a surgical repair of the meniscus, they will often require periods of controlled or reduced or non-weight bearing, plus or minus range of motion control. And when we think about the structure of the meniscus and the fact that there are those circumferential fibers which convert that axial load into circumferential stress, if the structural continuity of those fibers has been compromised, as in a meniscal tear, it stands to reason that we want to reduce the axial load to prevent that hoop stress or circumferential stress whilst those fibers are trying to heal. Meniscal transplantation is another potential treatment option. So where the meniscus is extremely bad, really badly damaged, and in some cases beyond repair, meniscal transplantation is an option. It is only for countries, considering we're addressing countries across Asia Pacific here. I know there's countries where donor grafts and donor menisci, etc., are not permissible. But in those countries where it is permissible, it is certainly something that is a possible treatment for the acute meniscal tear. So this is an example of a post-surgical rehabilitation following meniscal repair. So a meniscal repair protocol is more conservative than a meniscectomy protocol. But here we can see that in these first 6 weeks, there's going to be potentially weight-bearing restrictions, range of motion restrictions, and there'll be bracing day and night. So whilst this mentions that it can progress to full weight bearing or partial weight bearing and full weight bearing in this first 6 weeks, a recent discussion I had with one of the head physios from a very high profile sports injury clinic in the States, they are completely non-weight bearing for all meniscal repairs for 6 weeks. Range of motion, they will be in a knee immobilizer for the first 6 weeks, apart from when they have physio, at which time for 2 weeks they'll allow 0 to 90 of passive motion, and they want to avoid active knee flexion. And then beyond 2 weeks, they'll allow free motion, but it'll be in a controlled setting only for physio, and then back into a knee immobilizer for the remainder of the day for that first 6 weeks. So certainly the exact range of motion control and weight-bearing limitations will depend on the location of the repair, concurrent knee injuries, the referring doctor, the patient themselves and what they're going to tolerate and their compliance, all sorts of things. But I thought I would put this up there as an example of a potential rehab program following meniscal repairs. So from a bracing perspective, you can see that from a weight-bearing perspective, we can provide bracing that affects this. Range of motion control, we certainly can control that. And from a brace perspective for day and night wear protection and range of motion control, we've got something that can cover right throughout these rehab protocols. So given the meniscal repair, what we've established is that the meniscus needs to be protected from axial load, and that will be protecting or reducing weight bearing. There's the chance that we may need to provide range of motion control, and we're going to protect the structures during activities as they progress through rehab. An option may be something like Össur's rebound cartilage, where it builds on the same technology as the unloader one, where we've got a unilateral upright on the affected compartment, our two diagonal straps to create the unloading of that affected compartment. But we also, in this case, have the ability of adding a contralateral hinge, where it then provides us with full range of motion control as well. So it can all be done within the one brace. Obviously, depending on facilities, depending on budget, some people may use a knee immobilizer in the early stages and then look at something like an unloader, for example, for ongoing. But this is just an option where it is all in one. For those acute tears that do undergo meniscectomy, as I said, the main thing from a physio perspective is that they really want to maintain joint range of motion and joint strength. From a activity perspective, what they will want the patients to do is modify their load activities. And this is simply to protect or preserve the joint, because as I keep saying, as soon as the material from the meniscus is removed, as in a meniscectomy, regardless of whether it's partial or a full meniscectomy, the load that is being taken by the articular cartilage increases, and that's obviously going to increase the degeneration and the progression of that degenerative joint disease towards the varying stages of osteoarthritis. So it stands to reason for those patients who have had meniscectomies, and it could be someone who has recently, or it may be someone that presents with a history of partial or full meniscectomy, that an unloader one or an unloader fit to unload that affected side of the knee that they've had the meniscectomy is going to prolong the life of their anatomical knee joint. Chances are they're already going to have some damage to the articular surface, but by unloading that affected compartment, we certainly have the opportunity to provide joint longevity. So the degenerative meniscal tear is the other main category, and unlike the acute traumatic meniscal tears, these tend to affect the middle-aged to elderly patients. These tears generally have a complex tear pattern, so they're not just a nice clean tear. There'll be a complex tear pattern, mainly in the posterior horn and mid-body, and they're often associated with wear and tear. So wear and tear is one of those terms that we certainly associate with degenerative knee joints and osteoarthritic knee joints. And these degenerative tears are typically seen in that same category, middle-aged, older patients, and they can accompany knee osteoarthritis or they can occur in isolation. So it is possible that someone can have a degenerative meniscal tear in isolation, and in this case, these cases it's thought of as being pre or early OA. It's possible that they have had a degenerative meniscal tear for a period of time, and then spontaneously or following a very trivial event, and that can be stepping off a curb, pain can present, and that's when they get it investigated and that's established that they've got a degenerative meniscal tear, plus or minus any arthritic change. Generally, because of this complex tear pattern and the location of tears towards the internal joint surface or that white zone, they don't have a great healing potential. It's thought that 35% of patients of 50 years will have a degenerative meniscal tear, and that increases up to 60% of people 65 years and above. So this is an interesting table, and please ignore this red square here. When we think about Australia, and I apologise to those outside Australia in the APAC region, but this is the statistics that I've got. Here, if we look at mild or moderate OA, we've got a prevalence of about 640,000, increasing up to just under 900,000 if we include mild, moderate, and severe. But there's over 1 million people currently thought in Australia to have a degenerative meniscal tear. And as I said, not all of these will be symptomatic, but there is a chance that spontaneously they can present with pain and other symptoms. So from a prevalence perspective, I think that's why the degenerative meniscal tear really deserves notice. And then when we look at some of the changing trends, you'll see why the degenerative meniscal tear, from an allied health professional, from an orthotist, physio, etc., it's something where we can have a profound effect in the conservative management. So patients that are at greatest risk of degenerative meniscal tears are those with a body mass index of over 25, those that are over 60 years of age. Males have a 3-time greater prevalence than females. Those that are involved in work that involves kneeling and squatting for greater than an hour a day, or stair climbing greater than 30 flights a day. So that again is that weight bearing on a flexed knee. They're the ones at greatest risk of developing these degenerative meniscal tears. Again, the risk factors, this is from an article which was a sort of a systematic review of all the different risk factors, but they were the main ones that had the highest increased risk. Symptomatically, again, pain, and it can, as I mentioned, just spontaneously occur. They can have associated locking or pseudo-locking. So it's important to establish whether the reduced range of motion is actually because of the meniscus being caught between the femur and the tibia, or whether in fact it's from an effusion or that build-up of fluid within the joint because of inflammation, swelling, etc. Patients will potentially have catching sensation if there are loose fragments, and feeling of instability is possible as well. Pain tends to be somewhere in that 4 to 6 range, but it can go higher when it first has an onset associated with particularly when it's associated with a twisting motion. It can set off pain, but as I said, it can be spontaneously or just as a result of stepping off a curb. Meniscal tears are shown to decrease walking endurance and balance, so that balance can certainly be explained by the proprioceptive function of the meniscus. Degenerative meniscal tears can be both conservatively or surgically treated. From a conservative treatment perspective, some of the key goals in the rehabilitation will be getting pain under control, preserving and improving range of motion if there's been any loss there, allowing the patients to get back to full activities of daily living, and they will want to be involved in a strengthening program, and they will also want to prevent OA, the onset of OA or the progression of OA if there is already associated arthritic change. From a surgical perspective, the procedures again are these meniscectomies or meniscal repairs. generally, it will be removal of any loose body. So if there are fragments that have come loose of the meniscus and are floating around in the joint capsule itself, they'll be removed. Potentially they will undergo partial meniscectomy if there is binding or catching in the knee. And ideally they'd like to be able to do meniscal repairs, but this tends to be they don't tend to have as good outcomes in the degenerative meniscal tears because of the lower potential to heal. And some of that is the location, some of it is the tear types and patterns, but also the meniscus tends to undergo degenerative change, much like other connective tissue. And given that it's predominantly collagen fibers, it stands to reason that essentially it becomes a little bit more brittle as we age. So whilst we have this surgical and conservative treatment options, and historically, I guess, we've all seen patients where they've had a meniscal injury and they've just had the complete meniscus removed, so a total meniscectomy. And it's not really that long ago that was a common procedure. But more and more, we are seeing a real shift towards conservative management of these degenerative meniscal tears. And again, from a bracing perspective, this is something where we again have the ability to have an effect. So some of these articles here, which I'll expand on here, just support this evidence base of shifting away from meniscectomies and where possible and towards the conservative management. So even as early as 1949, it was established that patients that underwent meniscectomy resulted in narrowing of the joint space and broadening of the femoral and tibial condyles on that affected side. So even as early as that, they're talking in the language of this arthritic change. And what they concluded from that was that a meniscectomy is not innocuous and it interferes with the mechanics of the joint. And it seems that narrowing of the joint space will certainly predispose them to early degenerative changes. So as early as 1949, this was established. More recently, and this was an article from 2013 that compared patients with degenerative meniscal tears that underwent either a partial meniscectomy to sham surgery. So a very interesting trial that all patients thought were under the impression that they would have a partial meniscectomy, and obviously they would have approved being a part of this trial. But 50% were given a partial meniscectomy. The other just had a scope put in their knee and nothing done. And what they were able to establish was that the outcomes after those that had the actual procedure done and those that had the sham surgery after 12 months from a symptom perspective were no better. But obviously those that had the partial meniscectomy now had removal of the meniscal material and now are faced with the potential for increased and a more rapid progression along that OA scale. A more recent study last year, again, the results were that no difference was found between arthroscopic meniscal debridement compared with non-operative management as first-line treatment. It did, however, say that for those patients that had mechanical symptoms, so they were having that catching or locking of the joint, they are the ones who would benefit from meniscal debridement. So they made this delineation that for those that didn't have locking of the knee, conservative management. But for anyone who had the locking, then yes, go ahead, remove that material that is impeding normal knee joint range, but otherwise conservative management. What else does the evidence suggest? So a randomized trial showed that arthroscopic meniscectomy, partial meniscectomy, combined with physical therapy gave no better relief of symptoms than physical therapy alone for patients with meniscal tears and knee OA. partial meniscectomy associated with increased risk of incidental OA and worsening cartilage damage even as early as the following year. Patients with knee OA, in patients with knee OA, arthroscopic knee surgery with meniscectomy resulted in a threefold increase in the risk of future knee replacement. And those that underwent partial meniscectomy had significant loss in knee joint position sense or proprioception. I will, however, put this as the caveat to all of this in that, again, where patients have mechanical symptoms, the meniscectomy is still performed and is still indicated. So I'm not saying that meniscectomies aren't occurring, it's just that they're not occurring as often as they were in the past, and there is that shift away towards more conservative management when there are no mechanical symptoms evident. And the various orthopaedic societies are certainly confirming this. So the Dutch Orthopaedic Society, the British Orthopaedic Association, and more recently, as late as October of last year, the Australian Knee Society, which is a chapter of the Australian Orthopaedic Association, came out with a position statement stating that partial meniscectomy is not indicated as an initial treatment for atraumatic tears of degenerative menisci. Again, they've mentioned that where they are bucket handle tears and there is associated locking, then that's when a meniscectomy would occur. So given that we've got this shift towards conservative treatment, from a bracing perspective, we have the ability to provide pain relief, and certainly we've got the ability to prevent OA onset and progression through joint unloading. And we've got plenty of evidence here to suggest that Össur's unloader braces can achieve that. So obviously from an OA perspective, we've got a deep backlog of clinical evidence, and I can show you where you can find out about that for those that are using the OA, wanting to use the Unloader 1 and Unloader Fit for OA. But we've now got a recent study that was completed late last year, specifically using the Unloader Fit for the management of symptomatic degenerative meniscal tears without locking or blocking. So this is that category of patients where we're seeing the change that we want to conservatively manage these. They are presenting with pain and loss of function, and this is the study that was recently completed. So it was a relatively small trial. It was only 14 subjects, but they were subjects with a degenerative meniscal tear. They were assessed at baseline and then after 1 month and 2 months of brace use using the WOMAT, which is a sort of disease-specific health quality of life measurement tool, so similar to WOMAC, which is used for knee osteoarthritis, and also the visual analog scale for pain. So we're looking at pain and quality of life outcomes here. So we had patients between 35 and 65 presenting with medial joint pain and an identified degenerative tear of the medial meniscus via MRI. This study excluded patients that had grade 2 OA or higher, and I guess the reason being is we've already established that the Unloader 1, Unloader Fit is clinically proven as a treatment option for osteoarthritis. So we wanted to look at this as purely managing the degenerative meniscus and symptoms related to that. So what was able to be shown was that from a WOMAT perspective, looking at the health-related quality of life, which has subdomains of physical symptoms, activities and emotions. They wanted to see from the minimal clinically important difference, this MCID, they wanted to see a 15-point improvement, and they managed to show a 22 percentage point improvement, confirming that the quality of life, or the health-related quality of life associated with degenerative meniscal tears was improved. And I guess from a patient perspective and a symptom perspective, patients always present with pain. That's the number one symptom that patients are going to present with. So they were able to show statistically significant reductions in pain from baseline to 2 months. And it was this 14-point reduction on a 0 to 100 scale for visual analog scale. So this confirmed, yes, statistically significant reductions in pain, but I think from a patient's perspective, it's really a clinically significant reduction. You can imagine if you were the patient with pain, to have a reduction in pain would be hugely beneficial. So we've now got a brace that is proven to have benefits both from quality of life and pain reduction for degenerative meniscal tears. And obviously, if you've got a degenerative meniscal tear with associated osteoarthritic change, which is common, we've got the unloader fit and unloader one, which are certainly proven for OA management. So what we know is that loss of meniscus, and that can be following degeneration of the structure or removal via surgery, results in loss of shock absorbency. It results in increased coefficient of joint friction. So that sponge analogy is being lost. We've got reduced joint stability. We've got disrupted joint homeostasis. We've got reductions in joint lubrication. And these are all contributing factors to degenerative joint disease and OA. So for those where we're removing meniscus or losing meniscus as a result of injury, unloader is certainly a brace that can assist. So degenerative meniscus we've discussed, and obviously the depth of clinical evidence that the unloader one is profound, and you can find this on our website. So ranging from the design of the brace being that unilateral upright on the affected side with the dynamic force straps, through to pain outcomes, functional outcomes, and even the fact that it can be used as a treatment modality to delay surgery. Most recently, the 2012 study by Briggs showed significant improvements in pain, stiffness and function, and demonstrated significant decreases in pain and disability for patients with unicompartmental knee OA. So take-home messages. The treatment of degenerative meniscal tears can be approached conservatively or surgically. Current data is suggesting that the majority of patients can certainly be successfully treated without surgery. So those patients without blocking and locking. Those patients with blocking and locking shall still be considered for surgical treatment, being meniscectomy, or ideally the partial meniscectomy of the damaged area. In both of these cases, we've got products that support the rehabilitation of degenerative meniscal tears. So conservatively, we've got a product that is shown to reduce pain and improve quality of life. And in both the conservative and surgical, where there is loss of meniscal volume, we've got something that can offset the associated increases in peak pressures, so unloading that affected compartment. And obviously the unloader one, unloader fit are clinically proven for the conservative management of unicompartmental knee OA, for which meniscal injuries are certainly a precursor. So from a prevalence perspective, we've got a category of patients that are certainly growing. We know that this is 35% of patients over 50 or 60% of patients over 65. And given that we've got an aging population, these numbers are bound to increase. We've got a trend away from the removal of meniscus and more towards the conservative management. And we've got a brace that is now clinically proven to increase quality of life, reduce pain, specifically in those with the degenerative meniscal tears. So that's something that I would encourage you to discuss with your referring doctors who, based on the evidence, will probably be potentially reducing the number of meniscectomies that they are doing on degenerative meniscal tears without locking, and they're probably looking for some options to help their patients have positive clinical outcomes. You know, chances are the surgeons are still going to catch these people down the track because they're going to continue to progress and go into the OA scale. But we've got braces that can manage all components of meniscal injuries, whether it's an acute injury, a degenerative injury, whether it's conservatively managed, whether it's surgically managed. And then we've also got these braces that are clinically proven for the management of osteoarthritis. I really would like to thank you for your time, for your interest. If you do have injuries, and I know we've given time that we may not get to those now tonight, but you are certainly welcome to email me directly. And I'd encourage you to contact your local Össur staff member, wherever you may be, if you're interested in arranging a product demonstration and finding out more about these products and where you can use them to maximise their clinical outcomes for the patients that are presenting in your clinics.